My task was to talk to you about IBD and COVID, which, as you all know, is a relatively hot topic these days. A few caveats to start with. So the slides have been reformatted, and therefore some of them may be off-killed. So I'm going to try to walk you through that part. And these are my disclosures. This is the program disclosure. So what am I going to talk about in the next 25 minutes or so? We're going to review the incidence and outcomes of COVID among IBD patients. We're going to understand the risk factors for COVID complications. And then at the end, I'm going to have a more ample conversation about the role of COVID vaccines, efficacy, and the role or importance of these boosters. So from the very beginning, we had several questions related to COVID in IBD patients. We wanted to know, or we weren't sure if IBD patients were at increased risk of COVID-19 or complications thereof. Can COVID-19, being an infectious disease, cause flares of IBD? And then once the vaccines became available, we wanted to know if they're safe and effective for our IBD patients. And then now, the more and more active question is how many doses or what is the optimal dose for optimal protection. So I'm going to make some caveats here. Obviously, in my talk, I had to be a little bit scholastic. So I'm going to show, there will be several slides that are fairly technical with plenty of data, because I don't want you to think that I'm pontificating these conclusions. I want to show you where the data, where the evidence is coming from. So I tried to strike a balance between scholastic and some straightforward conclusions. I'm also showing you here a modification of the Gartner cycle. Some of you may know the Gartner cycle of innovation with a spark that triggers an idea, and then the extreme enthusiasm, disappointment, and then constructive evolution. So I tried to adapt that to what happened with COVID over the last 2 to 3 years, starting with the beginning when there was a lot of panic and confusion. We thought that all immunosuppressive drugs are bad. And then we started gaining some knowledge. We learned that immunosuppressive drugs are actually safe, but steroids are bad. And then we moved to more knowledge, vaccine optimism initially, and then vaccine confusion once we did not know whether there are enough doses as for the general public or patients with IBD need more. 2 or 3 eventually became 3 or 4. So I think we are now, and I apologize for this because it's not projecting well on this format, but I think we're in that slope of mature enlightenment. We're actually learning, as you will see towards the end. We're sort of building the plane as we fly, but it's not as bad as it sounds. So let's see how these steps evolved over time. Why the initial panic and confusion? Well, we knew something about infections in patients with IBD, right? IBD patients are immunosuppressive therapy. This is the lecture that all of you who are IBD patients have had with your providers, hopefully, when it was discussed the case of immunosuppressive therapy, that these drugs increase the risk of infections, sometimes serious infections. Of course, they're uncommon, but they're there. Opportunistic infections are also there in patients using immunosuppressive drugs. So all this did not bode very well with a new infection that we knew nothing about. And besides that, the general folk, the population, had no immunity against beta coronaviruses. These are new. The reason we called COVID the new coronavirus is because there was virtually zero population immunity, right? That bat or Chinese lab or whatever the source was, they had absolutely zero exposure to humans until that first nucleus in Wuhan. Moreover, the target for the S protein, which is that spike on the surface of the virus, it's called ACE2, it's pretty well represented in the intestine, especially in the lower part of the small intestine and colon, which is exactly where Crohn's disease and to some extent ulcerative colitis likes to live. So many questions and concerns there that we try to clarify very quickly. And I want to highlight that the speed of learning, the amount of knowledge we accumulated on this disease, it is extraordinary. Just as extraordinary as the pandemic was, our learning was equally fantastic for the way science, based on the pace that science normally advances. So these are the first pieces of information that we started gathering. Of course, we used every resources we have. The first one is from an international database of patients with IBD and COVID. That was the strength of this database, which is still actually accruing, ongoing. It's called Secure IBD, is that it truly accumulated data from around the globe. On the other hand, it's voluntary, so lots of biases there. But we learned that actually anti-TNF therapy at least was not associated with an increased risk. Instead, age was a risk factor, as it is today. And when you see that adjusted ratio there of 104, that's per year. So that basically means that with every decade, the risk doubles, as I'll show you in a little bit. Comorbidity is also a big modifier. And steroids were the worst. Increased the risk of complications 7-fold. That's what we thought back then, 2 years ago. We also learned that IBD patients were more likely to be hospitalized despite the fact that they had milder or similar symptoms with patients that were treated as outpatients. So there was a bit of a bias there, a tendency to admit patients to the hospital if they had an immune condition. And that, as I'll show you in the next slide, that applies to about every system, healthcare system throughout the world. They're also younger compared with controls by a decade, 63 versus 72. Note that that was the median age of the hospitalized patients at the beginning. So again, age will come back and again as a risk factor. With that though, patients with IBD who were hospitalized actually had lower risk of complications from COVID. Fewer of them made it to the ICU, as you can see there, 12% versus 16%. Fewer of them ended up on the ventilator, which is a major complication. Of course, half actually compared to controls, and less than a third actually died compared to other patients without inflammatory bowel disease once they got to the intensive care unit. And this is basically data from Providence. Providence, which Swedish is part of, is a very large healthcare system, spans the entire West Coast. So obviously we had a very large number of patients. If you start from the left column there, patients were tested for COVID, you realize that we're talking about 80,000 or so patients with immune-mediated disorders. This includes IBD, 30,000 patients, but we also had rheumatoid arthritis, ankylosing spondylitis, lupus, multiple sclerosis, and so forth. And actually what we noticed is that the percentage of patients who got COVID was less compared to the general population. So I'm not saying that IBDs necessarily or immune-mediated diseases are protected against COVID. I think our patients are more careful when they go about. They're more likely to wear masks. They're going to wash their hands. They're going to follow all these public preventative measures as opposed to the general population. Again, these are associations that are not causality. But what was clear, as was the case with other studies, is that more IBD patients were hospitalized. Percentage-wise, there was a higher chance that patients with IBD were hospitalized. So again, the bar was lower in the ER. But on the other hand, they didn't do any worse compared to patients without immune-mediated conditions. So controls are the second row from the top. If you scan across that row, you will see how there's no difference in serious outcomes, at least, between patients with IBD, any other immune-mediated condition, or controls without immune-mediated conditions. Same thing all the way to mortality, which was actually quite low, fortunately. And then we had data from the epicenter of COVID. So this was boots on the ground, a bit more sophisticated and a bit more reliable, because this time it was reported on an individual basis, so all individuals included. Again, there was a signal for less severe COVID as far as the serious complications, so ICU, ventilation, or death in IBD versus matched controls. But we also learned that active IBD, specifically ulcerative colitis, or being on no treatment, patients who were on no treatment for their IBD tended to have higher risk, so worse outcomes compared to patients who are treated with any other immunomodulator. And you see the ratio there, 30% versus 6%. So active disease and steroids started to move into the focus. And then probably the best data we had in 2020 was from the VA very large patient set. So 31,000 patients, of course, most of them male and over 60. But that's where we learned again that obesity, comorbidities, and being on no medications increase the risk of serious complications. So then we were facing the steroid paradox, right? Steroids are both bad and good. Why good? Well, because there was a randomized trial showing that high-dose steroids are actually helpful for patients with COVID who develop pneumonia. It decreased the risk of ventilation, decreased the risk of dying of pneumonia. So how can this be? Steroids are bad, steroids are good. Well, it could be that this is actually a bimodal effect, right? So early steroids will foster viral replication with any virus whatsoever. And that's why patients who are taking steroids are at higher risk of infectious complications, not just fungal and bacterial, but also viral, as you probably know. But later, as you see on this diagram, they dampen, and on the right side, you see what's happening in the later stages of COVID. The body mounts a very, very ample, a very massive immune response against the virus, probably over-exaggerated. Where did you hear this word before? An overactive immune response is what happens in patients with immune-mediated conditions. RA, IBD, lupus, what have you. So the first phase of COVID is exclusively virus-driven. Viral replication, it spreads everywhere. You spread it to other people. You get some runny nose, congestion. The second phase, where the virus moves into the lungs, the body mounts this massive immune response. This is where the complications come from. So it's entirely possible then that the steroids play this dual Janus or Jekyll and Hyde effect, where early on they promote viral replication, but later on, if you know when to start the steroids, you may actually save lives. So not incompatible, not incongruent to have a bimodal effect of steroids on COVID as a disease in general, depending on the phase of the disease state or the state of the disease stages. So the other question was, can COVID-19 being an infection and triggering an immune response, can it cause IBD flares? Well, we had all sorts of reassuring data. This is again from the Epicenter. This was published in early 2021, but it was data primarily based on patients admitted or patients cared for in 2020, so prior to the advent of vaccines. Not too many, but 120 patients assessed before and after infection. The great power of this study was the thoroughness of follow-up, because they could actually verify the information for every individual in large detail. So they found no changes in the IBD clinical or biochemical activity. By that I mean biomarkers for inflammation. If you look down at the bottom in that table, fecal calprotectin, which is the number one biomarker that we use these days for all patients with IBD, did not change much before, during, or after the COVID episode. If anything, there was a slight dip following the infection. So it goes from about 400 up to about 500 and then back to 250. No significant difference based on statistics. Same thing when you just look at clinical symptoms, so active disease, virtually no difference before, during, or after the COVID episode. And if you look at the third bullet point there was no change in medication required during or after the COVID episode, which again suggests that nothing really changed as far as the disease activity. So I think the answer there is an emphatic no. And then we had the vaccine. So finally comes late 2020, early 2021, vaccines become available first, of course, first for populations at high risk. The problem was that in all the vaccine studies, patients with IBD and other immune-mediated disorders were excluded. Now, that's only 2 to 3% of the population, but for us, for our practice, it's 100% of the population. So no information on IBD patients. What do we do? So again, we started using surrogate markers, these famous antibodies that everybody here probably has heard about, serologies we call them. The problem is serologies may not reflect the true level of immune protection after vaccine, as I'll show you in a couple of slides. So recommendations came that COVID-19 vaccinations, preferably with the mRNA vaccine, because we have a lot more information about them, efficacy and safety-wise. Primary series plus 1 booster, strongly recommended for all patients, regardless of their immunosuppressive therapy. So that was all good. This is now end of 2021. We're pretty sure that that's the case. But then came out these other studies showing that, wait a minute, the immune response following an infection. So these are patients who at baseline were screened for previous COVID. 5% of them had COVID. And then they looked to what happened to the antibodies against the virus over time. And if you look at the orange bars, those are patients treated with Entyvio or vedolizumab. This is not a systemic immunosuppressive, so it's not supposed to impair the antibody formation, the antibody immune response, versus infliximab, a systemic immunosuppressive who can impair antibody formation or immunity, the generation of the immune response, the production of the immune response in everybody, including patients with IBD. And what happened over time, those are basically weeks from the episode of infection, the antibody levels indeed were lower in patients treated with infliximab compared to patients treated with Entyvio. So infliximab being Remicade and its biosimilars, and Entyvio being Entyvio. So from that, we thought that IBD patients on anti-TNF may have lower protection following either infection or vaccines. There's no reason to think that vaccines would be any different than the infection, correct? Moreover, if you're on combination therapy with an immunomodulator, things were even a little bit worse. So further blunted that antibody response. But then we had the good news. So this is now late 2021, early 22. We put together these large consortiums. So 3 throughout the United States, West Coast, East Coast, and kind of central. Many IBD centers got together and collected data on thousands of patients this time with IBD, exclusively IBD, and we tried to understand what happens to their immune response to vaccines. And we found out that actually the situation is quite a bit rosier. 95% of IBD patients had detectable antibodies after 2 doses of vaccine. But there were some factors associated with lower, what we call seroconversion, so ability to mount an immune response enough to knock out the virus. Again, age over 60. Interestingly, there was a little bit of a difference between vaccines. So the BNT, that's the Pfizer vaccine, appeared to be a little bit weaker than the Moderna vaccine. Part of that is due to the concentration. So in the booster, Pfizer formulated a different concentration of vaccine compared to Moderna. Be it as it may, that's what we found out. And then combination therapy obviously seemed to blunt the effect. There was also a trend for steroids, which no matter how you look, they end up in a bad color here, unless, again, you're in the ICU with pneumonia. What was very interesting is that we found that the highest possible titer was seen in patients who were hybrid immunized. What does that mean? You got 2 doses of vaccine plus COVID, the real COVID infection. Those patients had sky-high antibodies and very robust T-cell immunity that trounced all boosters possible. Now, that's data from the alpha, beta, and delta wave. We don't have yet data from the Omicron, but we think that the booster conferred by the Omicron is not quite as strong as the booster conferred by the Delta vaccine. So that may or may not have any repercussions down the road. The bottom line is hybrid patients, keep this in mind because we'll come back to it in a little bit. Hybrid immunized patients had the highest level of immunity of any of our patient population, including those with 2 doses or 3 doses of vaccine. So where did the need for a booster dose come from? Well, we learned also, as we knew from the registration trials with vaccines, that vaccinated people can still develop breakthrough infections, although the vast majority are mild. Antibody titers can wean over time in everybody, a little more so, as I said, in patients who are immunosuppressed. And in some studies, breakthrough infections were associated with low antibody titers, although, again, most of these infections were mild. And if you look on the right side in that table, basically what they show you is the stratification of these patients, this time with IBD alone, 2 months after the vaccine, and where did their antibody titers fall. And the more immunosuppressed they were, the patients, that is, the lower the level of antibodies. So there was an association between severe immunosuppression and titer of antibodies if you look far enough. In other words, the antibody levels fall faster in patients who are on combination therapy or more severely immunosuppressed. What made matters worse is that our colleagues from transplant medicine also showed us that some patients who were receiving anti-rejection medications after transplantation had almost no antibodies after 2 doses of vaccine. Now, it's important to highlight here that patients on anti-rejection medications are much more immunosuppressed compared to the overwhelming majority of patients with IBD or other immune-mediated conditions. So again, more good news. This is all data from early this year. Antibody response after a 3rd dose of vaccine, so this is 1 booster. Virtually everybody mounted an immune response, including 96% of those who previously had no antibodies after only 2 doses. So very, very reassuring again. And it didn't seem to matter which medication you're on, except for one class of drugs, the S1P receptor modulator. Some of you may have heard about them. We have one representative now in the IBD space for ulcerative colitis, and that's ozanimod. It doesn't mean that patients who are taking Zeposia or ozanimod are at higher risk. They just have lower antibody levels if they got the vaccine after they started the drug. The reason I like this other study, this is from the East Coast, kind of the partners, so the New England area, is because they actually show not the impact of vaccination on antibodies, but actually on true infections. So these are all these patients were vaccinated, as you see, very, very large number of, very large patient population, almost 900,000 vaccinated subjects. Among these, there are about 5,500 IBD patients. Half of them are on immunosuppressive therapy, including solid combination therapy. And they found, if you look across the top there, no difference in the risk of breakthrough infections between patients who had IBD or non-IBD. And in fact, the majority of breakthrough infections in patients with IBD happened after the 1st dose. After the 2nd dose of vaccine, very few patients actually developed, symptomatic at least. They may have become colonized with SARS-CoV-2, PCR positive, but they had no idea about it. So very, very good news. And if you look below that, adverse events from the vaccines, of course, adverse event hospitalization within 30 days, all very, very reassuring as far as vaccines in patients with IBD, both protection and safety of the vaccine. No difference in steroid prescriptions 1 month after vaccination. What does that tell you is that the vaccine did not cause a flare, which is an idea that we visited earlier. Conclusion here, no difference in the efficacy or safety among patients with or without immunosuppressive therapy. And as I mentioned earlier, most breakthroughs occurred after the 1st dose. This is another very interesting study. This is from the Netherlands. They had a large cohort of patients with immune-mediated conditions, about a quarter of them with IBD. This is just to show you that the drug that you're on matters as far as the antibody levels, but that's it. It doesn't really relate to any risk of infection or complications from the infection. And again, if you look across the board there, the only medication that really matters to us is this. My mouse projects there, it doesn't. But it is the S1P, so the S1P receptor modulators, which tend to blunt the antibody response. The other drugs we don't use so much or very frequently. MMF, this is primarily a drug used for transplantation, sometimes also used in patients who have lupus or other serious immune conditions. And anti-CD20, sometimes, actually rheumatologists like that class of medications for patients with more refractory rheumatoid arthritis, but we don't use it in IBD. So some difference between drugs, but the important notion here is that if you look at the majority of the drugs that we use nowadays in IBD, including anti-TNF, Vito, ustekinumab, and so forth, no difference in antibody formation. And this is what happened after the third dose. Again, there appears to be a blunted response in patients taking some medications, including these S1P receptor modulators. And even after the third dose, they still don't mount that immune response that we see on the right side. These are patients who are controls or taking all other medications, or patients without immunosuppressive therapy. I apologize. These are patients who are on methotrexate alone, on thiopurine alone, or anti-TNF. And as you can see, after 2 doses, they're at the 98% or so, and after 3 doses, virtually everybody's at 100%. So some difference in the antibody result, in the antibody formation, and the medication for that specific immune disorder. COVID vaccines do not cause IBD flares. Again, a large number. This is another one of these consortiums, 3,300 vaccinated IBD individuals. There was a reaction after the vaccine, more so after the second dose, so 12% versus 3%. They found some predictors for these severe systemic reactions from the vaccine, being young, female. Interestingly here, the Moderna vaccine tend to cause more reactions, and having a previous COVID infection also was associated with a higher likelihood of a severe systemic reaction from the vaccine, which kind of makes sense because I told you earlier, a hybrid immunization, vaccine plus infection, gives you the highest level of immunity of any combination whatsoever. But despite all that, only 2% of them had a flare within a month of the vaccine, which is totally what we expect to see as a background noise among patients with IBD. At least 2% experience a flare on a monthly basis. So very reassuring. Therefore, the question came, who should receive a 4th vaccine dose before March? A very small segment of the immunosuppressed population, the so-called severely immunocompromised, and those were patients who received active cancer treatment, organ transplant, stem cell transplant, primary immunodeficiency, HIV, AIDS, or high-dose steroids. Of course, those changed after the end of March, so the updated CDC, they allowed some laxity. So patients over the age of 50 with certain comorbidities, very vague if you really think about it. So CDC kind of left the door open there for interpretation, but certain underlying conditions and age over 50 became a criteria for a 4th dose. Where did that recommendation come from? So this is where things get a bit technical, but I just want to show you that the evidence is relatively thin, right? So this was a study from Israel, subjects over the age of 60. Actually, more than half of them were over the age of 72, who got in a healthcare system. Some of them got 4 doses, some of them got 3 doses of vaccine, totally voluntary. They opened essentially vaccination to everybody who wanted to get it. Some patients got it, some patients didn't get it. And then they tried to see if there is a difference between the two groups. The thing is that these, if you really kind of look at the data, these are fairly sick people. So almost 2/3 of them had more than 2 CDC recognized risk factors for severe COVID. More than 40% were actually obese, which is an important risk factor. There were several with diabetes, heart failure, COPD, and so forth. And they found a relative reduction of about 45% in the risk of becoming PCR positive. That's called an infection. We don't know if they're symptomatic or not. But then when you really look at the nitty-gritty, so what matters, right? Hospitalizations, severe infections, and mortality, this is less than 1/5 of 1% reduction in hospitalization, less than 1/10 of 1% in severe infections, and very, very small difference in mortality. The more interesting part of this is that they show here this is the mortality curve, and then trying to tell us that from day 7 and on, there was a difference between the control group. These guys got only 3 doses of vaccine, and the 4-dose group obviously got 4 doses of vaccine. But if you really look at the data, the death rate among individuals 65 or older in the United States in 2019, so this is before COVID, was 4.7 deaths per day. In the 4-dose group, it was only 0.3. So there's only 2 ways to read this. Either the vaccine rejuvenates people. If that's the case, I will get one every 2 weeks. And you should too. Or these are ultra fit individuals who, for whatever reason, decided to get the 4th dose. They wanted to keep jogging through Tel Aviv and Jerusalem and places like that without the fear of getting an infection. There's no other way to explain this very low mortality in that 4-dose group. Even the 3-dose group had a mortality that's below the average mortality in 65 and older in the US before COVID. So something doesn't jibe there, and that's why I'm saying these are association studies. They're not causality. There's not strong evidence. But the caveat here, or the onus here, is on safety. Nobody had the risk of a severe reaction from a 4th or 5th dose of vaccine is very, very low. 1 in a million, 1 in 1.2 million actually. So very low risk, and therefore, why not, right? More could be better. There are some studies suggesting that that may not be the case, because this is another way to look at that. So this is now data from the US showing the risk of infection by age group, by age bracket, hospitalization age bracket, and death by age bracket. Reference group here is the younger population, so 18 to 30. And basically, as you can see, the risk of hospitalization increases, it doubles, it triples, it goes up 5-fold at age 65 and older. But the risk of dying is actually much, much more substantial, right? So 65 times for the 65 to 74-year-old bracket, and a whopping 140-fold. This is in the US, by the way, in the 75 and older and so forth. So clearly, age is a driver, right? So where did that age of 50 come from? I think it's a combination of that study from Israel and our own evidence that there seems to be a break point here around the age of 50 as far as the more severe complications. The controversial part here is that our immune system is actually much more clever than we think it is. So this shows you that there are several levels of immunity against COVID, including the first-line defense. That's what we call mucosal immunity. You can only get this through a natural infection. The vaccine is not supposed to give it to you unless you have a live vaccines. Those are not available in the US yet. So basically, the spray, the nasal influenza vaccine that was used a few years ago, that was an example of a live vaccine. Measles, mumps, rubella is another example of a live vaccine. So very, very few. We don't have a COVID live vaccine in the US, and there are very few in the world because people didn't have very good results with them. But that's really the only way to get first-line defense, and that will protect against any kind of infection or reinfection, including becoming PCR positive. The next level is this famous thing that you see in every newspaper, the antibodies, right? So that's called the serological immunity. You can get that, of course, through natural infection, but also with the modern vaccines that we have now for use. And you can also get it with monoclonal antibodies. Very few patients have probably received these monoclonal antibodies because given the variant shifts, the monoclonal antibodies tend to become obsolete very quickly. They don't neutralize the newer and newer variants. But some of them are still available and effective. So that's how you get that. What it does is it works relatively quickly. It's not immediate, but it works within hours, 24 hours. And it prevents you from getting a symptomatic infection. Doesn't mean you cannot become PCR positive. You go somewhere and get tested because you want to go to Hawaii or any other place you want to go, and you say, well, I got the vaccine and I'm still PCR positive. How is that possible? You don't get protection here. You get protection in your blood. So you can still acquire the virus, although the virus is probably not going to do anything to your body. And then you have the other layer of immunity. It's probably more important than the other two, which is called cellular immunity. These are memory cells, long-term soldiers, both T cells and B cells. You get them through vaccines, natural infection. They kick in a matter of days. So they're not as immediate because those cells have to turn on, start kind of talking to each other, and start manufacturing very, very high level of antibodies. Our immune system is smart enough not to keep all the antibodies against every infection around because the blood will become honey after about 5 years of life. You will have only antibodies in your blood and no red blood cells. So the way to reconcile that is the body automatically tapers down the level of antibodies and instead produces these memory cells that are just like the wives. They never forget anything that you do ever in your life. But at the next mistake, they will wake up and they'll basically produce these antibodies in very, very high concentration. The problem is that that takes a few days, so you will not be protected against getting the virus or having a symptomatic infection, but you will be protected against a severe infection probably for decades. Now, we can't say that now because we only have 2 years worth of data. But that 2 years worth of data is now here. And that's been shown to be true. And here's that basically analysis. So this is after an infection. Obviously, with the vaccines, there's less time. But up to 24 months, these memory T cells are still there. Same concentration, same ability to activate the antibody generation cascade. They're not making antibodies themselves, but they tell other cells to start making antibodies. So as of now, we say only 2 years. I'm sure we'll have a conversation 2 years from now, and I'll tell you it's 4 years, and it'll be 10 years, and it'll be 20 years. This is after only 2 doses of vaccine. I repeat, 2 doses of vaccine. So who should receive a 4th dose? Nonetheless, again, keep in mind that this is a safety issue. Because the vaccine is so safe, you can always recommend a 4th dose. So most IBD patients on immunosuppressive therapy are not severely immunocompromised and therefore not at increased risk of complications. However, there are some exceptions, and I think I showed you this multiple times. Age over 65. In every single database, in every single patient population, where it's from here, Israel, any other part in the world. Older age, for some reason, seems to be a problem, probably because they also accumulate as people age. You start getting these other issues, some heart, some lung, some diabetes, some kidney disease, and so forth. Patients who are taking high doses of steroids, so more than 20 milligrams for a month, continuously, or during the time they get the vaccine or they got the vaccine. Patients who are on S1P receptor modulators, I'm not saying that they are severely immunosuppressed, but at least based on antibody levels, I would encourage them to get a fourth dose. If the vaccine was given while they were, if the third dose of the booster was given while they were on the drug. If they got the 3 doses before they received their medication, their levels, their protection levels are going to be the same. So they have the same level antibodies. And then patients who are on atypical immunosuppressive regimens, very few, but we have a few patients with more complex IBD, more refractory IBD in IBD centers who are or have been prescribed these atypical immunosuppressives. And as you've seen in that previous slide, these tend to dampen the antibody response. So mycophenolate, tacrolimus, cyclosporin, or in these experimental environments or clinical trials where we use a combination of 2 biologics. It's not anti-TNF and azathioprine. It's actually an anti-TNF and ustekinumab, for instance. So things that you don't see every day in the world. This is a very important take-home message. COVID is a pandemic of all, but it's the ICU of the unvaccinated. This is data from August 2021. Large healthcare system in Indiana, so IU Health. We did a similar analysis in February at Providence, which we presented last week at a European Congress of Rheumatology. But this is basically the story almost everywhere. So they had, throughout this healthcare system, they had 60 patients hospitalized. Of these, 51 of the hospitalized ones were unvaccinated. This was at the time when almost half of the population in the US got the vaccine. It was late summer. So things were slowing down, but still half of the population were vaccinated. 3 vaccinated immunocompromised, only 3 were vaccinated, not immunocompromised. So this was the hospital. In the ICU, even worse. Majority unvaccinated, 2 immunocompromised, 1 healthy. On a ventilator, all unvaccinated. Our study virtually mirrored this. We're 2,000 miles away, same results. So this is a problem of the unvaccinated, not the 2-dose, 3-dose, or 4-dose, of the unvaccinated. Should you check your antibodies? This is another question that we get all the time. What am I doing here? Over. Okay, so I'd say no. If you're very curious, it may provide information about past infection, but it can also cause quite a bit of confusion and anxiety. Remember that, especially with Omicron, if you have been vaccinated, you may not develop antivirus antibodies. So your test may not show if you had the virus or not, if you had the vaccine, especially with Omicron because it causes a milder infection. So final thoughts, these are IBD recommendations, so International Organization for IBD. IBD patients should not interrupt medical treatment if they become infected. Exception, steroid taper. All IBD patients should receive 3 doses of mRNA vaccine. Exceptions, patients who had COVID, 2 may suffice. Certain drugs, steroids, MMF, and as I said, S1P, may need 4, and older age. Best time to administer a COVID vaccine in IBD patients is any time. Timing of the COVID vaccine should not be delayed or modified because the patient is receiving any medication or vice versa. Same day would work just as well. Vaccine efficacy for symptomatic infections may wane over time in everybody, not just patients with IBD. Again, severe infections appear stable over time with 3 doses or 4 doses. And keep in mind, this is the most common misunderstanding about vaccines and probably one of the most promoted misunderstandings that we unfortunately emphasized. The main purpose of the vaccine is not to prevent infection, is to prevent severe infection, hospitalization, and death. Mild breakthrough infections with new strains can happen, are happening, and will continue to happen, but they're not an indication for vaccine failure. So in summary, IBD patients do not seem to be at higher risk for COVID complications compared to healthy controls, except for high-dose steroids and maybe those with active disease. Background population risk factors apply to IBD patients: age, obesity, and lack of vaccination. ages by far seems to be the highest or the most important risk factor for COVID outcomes. Antibody response to COVID vaccines is robust in the vast majority after 2 doses and nearly universal after 3, with very few exceptions. Relationship between antibody titers and risk of severe COVID needs further work. Neither COVID nor vaccine seems to cause IBD flares, and that's it.
Thank you, Dr. Chiorean. It's good to see you. It sounds like we are able to maybe take a few questions because Dr. Chiorean is, I don't think, going to be here later in the afternoon. So are there questions? Yes, there are.
There. So the question was Novavax. Novavax is a newer generation of vaccine that's similar to the Janssen vaccine. So it's trying to circumvent this issue with variants, right? So the mRNA vaccines are still targeting the wild type, the alpha virus, which is long gone. It turns out that even if you use the vaccine, it will still be fairly effective against subsequent generations of this vaccine. Whereas if you give the protein, as in Janssen or Novavax, it tends to have better coverage for all variants, including Omicron, BA1, BA2, and so forth. It's not yet approved in the US, although it's available in Canada, not yet approved here. So the same idea applies there. You probably get a little bit longer, or you get longer coverage in terms of antibody formation, but as far as efficacy against the mRNA vaccines, we have zero data. It still requires a booster, so it's still a 2-dose now as opposed to the Janssen vaccine. So there's some modification compared to Janssen. But again, probably the more important application and what they're trying to emphasize with their vaccine is the efficacy against a broader population of variants. No idea. I don't even know if they applied to the FDA yet here.
Thanks. I think we're going to go over here.
Yeah, thank you for an excellent presentation, and I might have missed it, but real quickly, your thoughts on a fourth booster, whether it's necessary or not.
So the emphasis should be on safety, right? Because if you're concerned based on your level of immunosuppression and only you know the medications you're on, it's very safe to do. Whether it's efficacious in the vast majority of patients, we don't know, but the data seems to show that there's no difference between 3 and 4 doses of vaccine as far as the meaningful outcomes: severe infection, hospitalization, ventilator use, or death. Where it makes a difference is if you get a symptomatic infection. So the person who got 4 doses versus the person who got 3 doses was less likely to even have a runny nose or cough from COVID. But other than that, there was no difference in the other outcomes. Yes, please.
Yes, are you saying that if you're on immunocompromised medicine, in addition, I'm taking in addition to for Crohn's, that my chances of ending up in the hospital are pretty good at my avoiding ending up in the hospital?
Right. If you have been vaccinated, if you had 3 doses of vaccine, so the 2 primary doses and 1 booster, you should be protected as far as hospitalization or bad outcomes. You may still be more likely to get an infection with 3 doses of vaccine compared to the 4 doses of vaccine, meaning you get a symptomatic infection, you get a cough, but you're not going to end up in the hospital more likely with 3 versus 4.
So I can go to the casino for Mother's Day.
You can go to the casino, don't smoke, wear your mask if you go somewhere where it's public and people are yelling. Yeah, absolutely. So, but common sense matters, right? So the reason we think that our IBD patients, as I've shown in one of those earlier slides, are less likely to get infected is probably because they do the right thing. Wash their hands when they go to the bathroom, they wear masks when they're in public, take them off when they eat, put them back on. So they still lead normal. You don't have to be a hermit and live in an apartment for 2 years straight, as long as you're vaccinated and you follow common sense precautions.
Okay, thank you.
Yes. Go ahead.
Okay, so for a person that's diabetic, type 2, as I am, do you know anything about IBD and diabetes and how the two...
So the interplay there depends on how severe diabetes is. the more you add complications to the story with IBD, so Crohn's and diabetes, I'd say the more you can make a better case for 4 doses of vaccine rather than 3. Other than that, there's no interplay. Please.
So you've talked about 4 doses versus 3 doses. My first dose was J&J, and then I went on Pfizer. Is that going to give the same protection as 3?
As far as we know, so the question was, what if I got a Janssen vaccine? How should I boost that? At least based on the CDC recommendations, any mRNA vaccine to follow on a Janssen vaccine gives you an adequate dose of protection as with 3 doses of mRNA vaccine. So then you had hybrid immunization, you're more protected than anybody who got 3 or 4 doses. I would do the same mRNA that you did the first time. Although, again, if you had Janssen mRNA vaccine and COVID, you're more protected against COVID than any human on this planet. Last question.
Following infection or vaccination, what did you mean in that slide? And my second question was, similar to that question, so I've gotten the 3 shots and I got COVID, but I have multiple other complications. Would it still be okay for me to get a 4th shot?
So it will be okay. You are more likely to have a reaction from the vaccine, but you probably don't need it. One of the lessons we learned from these large consortium studies is that hybrid immunization, vaccine plus infection, gives you the highest level of immunity of any possible combination of vaccines. As far as your other question, following an infection, patients who are on, let's say, combination therapy, so anti-TNF, Remicade, Humira, plus minus azathioprine, had lower level antibodies compared to patients on vedolizumab. It doesn't mean that they had a higher risk of getting the infection. We just saw a lower level of antibodies, but that did not translate into worse outcomes. So what we learned is that actually vaccines do a better job, probably because you get all these repeated doses over time, in protecting you against the infection than the actual infection. But as far as bad outcomes, you're still very protected with 3 doses of vaccine, 3 plus 1 if you had COVID infection. So clearly you have a pretty good level of protection, and you may not need to have a 4th dose. 4th dose is still safe. I would wait at least 4 months since the 3rd dose, because otherwise it can actually cause tolerance. So your antibodies drop. Your body's beginning to think that, hey, this is a good thing for me. Give me the virus. It's a friend. So wait at least 4 months if you want to get the booster, but I don't think you need it. And there was a question. Yes. Yeah, so that's a great question. So can you get a booster dose of vaccine, the 3rd dose, if you are on high dose steroids? You can get the booster at any time. In that situation, I would go for a 4th dose 4 months later. So that's the one situation where we think the 4 doses may be of benefit. If you're on high dose steroids when you got the 3rd dose, wait 4 months, get a 4th dose.
Thank you, Dr. Chiorean. And thanks for your questions.